Our next speaker, Dr. Themba Moeti, is the Managing Director of the African Comprehensive HIV/AIDS Partnership, a public-private partnership between the government of Botswana, Merck, the Merck Company Foundation, and the Bill and Melinda Gates Foundation that supports and enhances the government's national response to the HIV/AIDS epidemic through a comprehensive approach to prevention, care, and treatment. So please, Dr. Moeti.
Well, good afternoon. And I'd like to first thank the organizers for having kindly invited us to make this presentation. And I think to thank Merck, who would otherwise have been making this presentation, but have asked that we, as one of the organizations that they fund in their HIV/AIDS work, to actually make a presentation on the work that HAP, the African Comprehensive HIV/AIDS Partnerships, does in Botswana. So let me first give a brief background on the African Comprehensive HIV/AIDS Partnerships. And this is a country-led public-private development partnership between the government of Botswana, the Bill and Melinda Gates Foundation, and the Merck Company Foundation. And as has been mentioned, its role is to support the national HIV/AIDS response in Botswana. And they've been doing this since 2001. And the two foundations and the company have made a contribution of about 106.5 million to Botswana's national HIV/AIDS response in our first phase, which was from 2001 to 2009, and a commitment between 2010 and 2014 of a second phase commitment of about $60 million US. And in addition to this, Merck is donating 3 of its HIV medicines for the duration of the partnership. And in the period thus far, the value of this donation has come to about $99 million US, which is a very considerable contribution to a country that was severely affected by HIV/AIDS, and as I'll illustrate later, which really is one of the biggest development challenges that Botswana is facing. And the intention of setting up the HAP was really to be a model public-private development partnership in the fight against AIDS, and to demonstrate how a partnership of this nature could make a significant difference to a major and significant public health problem. And unlike, I think, all the other speakers this afternoon, as you'll have noted, I don't come from industry. I come from a public health background, and of course, and actually we're a grantee organization of Merck's, but I think we will be using this to illustrate how they have contributed first to the control of HIV/AIDS globally, and also a significant contribution to advancing the progress again in the Millennium Development Goals in Botswana. And so I'll be using this partnership to illustrate that the work that Merck is doing and its contribution to the fight against AIDS. But I think the important aspect of this is that this is a partnership between a country and a government that is severely affected by this epidemic, Merck and a partner, which is the Bill and Melinda Gates Foundation, and really was to demonstrate how a public-private partnership of this nature, and I guess it's atypical in the sense that some may call it more philanthropic partnership, has actually been able to make a very significant difference. Very briefly, if one may talk about Botswana's HIV/AIDS response and the kind of support that's been provided. In our first phase, there was a focus on 4 areas: helping scale up prevention, improving access to HIV counseling and testing, where less than 10% of the population knew its HIV status in a country so severely affected by HIV/AIDS, and improving access to treatment, which I think was one of perhaps the signal achievement in our first phase, as well as advocacy for mobilization and empowerment of communities and people living with HIV/AIDS. And the second phase that we're coming into now is really one that is focusing on the area of prevention, and I'll touch on some of the prevention areas. And this is where really most of the challenges lie in terms of expanding access to prevention initiatives that have good evidence behind them, such as male circumcision, really addressing the tremendous vulnerability of women and young girls to HIV/AIDS and how this affects development and the potential for it, And then an important area where perhaps the greatest achievements were made in terms of the improving access to HIV/AIDS treatment and establishing perhaps was the first large-scale national HIV/AIDS treatment program offered by the public sector in sub-Saharan Africa and its success, and then moving forward with the challenge of addressing TB and HIV. And of course, we illustrate how those are related to the MDGs. Many people will know Botswana, those who do. It's a small country in sub-Saharan Africa, the middle of sub-Saharan Africa. But I think one of the things that Botswana became best known for was its fairly sustained economic growth since independence around 1966, when it's been averaging up about 9% growth on average in GDP per capita until around 2008. And this really was helped by sound development policies, and we achieved some fairly impressive improvement in some of the country's socioeconomic and development indicators in terms of infant mortality in the health area and under 5 mortality rate, in terms of literacy levels, which reached over 80%, in terms of improvement in life expectancies from figures as low as just about 40% in the 40s near independence, to 65 by around 1991, and a fairly sustained and impressive decline in TB from the mid-1970s, which had been the main cause of adult deaths in terms of public health problems in the country. And so investment in human resources is shown by a very significant investment in education, and then, of course, an economy driven mainly by the mining industry, but of course, that mining industry growth, which is mainly based on diamonds, has also been part of the country's vulnerability in terms of the strength of the economy. Now, if we try and focus issues around the Millennium Development Goals and the impact of Botswana's HIV/AIDS epidemic, I've tried to paint a picture of a country which has had very progressive growth and which transformed itself from one of the poorest, least developed countries around 1966 to a middle-income country by the mid-1990s. But I think what really was a major wake-up call for the country, and I think stopped this development in its tracks in some ways, was the advent of HIV/AIDS, which began in a fairly sustained way from the mid-1980s, when we had our first case in 1985. And within a period of about a decade, there had been a fourfold increase in mortality in young adults. The gains that I mentioned earlier in terms of improvements in infant mortality rates, and where we changed from a situation where infectious diseases were no longer a major cause of death in children, we then noted that we had an increase in infant mortality rate, in under 5 mortality, and many of the earlier socio-development gains that we had noted were being reversed quite relentlessly by the HIV/AIDS epidemic and its growth. And in fact, in the late 1990s, it was recognized that HIV/AIDS was perhaps our greatest health and development challenge. And if we were to reverse this, then the country would have to make a significant investment in fighting this epidemic. Perversely, one of the disadvantages of the kind of economic growth that Botswana was able to attain was that once you reached middle-income status, of course, a lot of the original official development assistance that the country would have received really melted away in the early 1990s. And so by the mid to late 1990s, many of the social development programs were really being funded with the country's own resources. And so facing an epidemic on this scale, it really was a major challenge as to how the country was going to cope, and some very difficult development choices needed to be made. And this was at this time that there really was a need to think creatively about what kind of partnerships could be looked into to make a significant difference. And I think this is where the opportunity of the African Comprehensive HIV/AIDS partnerships, with support from Merck and the Bill and Melinda Gates Foundation, became perhaps the most important contribution to HIV/AIDS and fighting the epidemic in the country in the 1990s, and I think heralded and inspired much more investment by other partners going forward. To give you some indication of the scale of the epidemic, between 1992 and 1980 and 2001 and 2002, the rate of HIV prevalence in the population, if we are looking at pregnant women, actually increased from about 18% to around 38.1% in 2001. This is really a tremendous growth in an epidemic which really had a very major impact on the country. About a quarter of the adult population is currently HIV infected, and as we speak, about 17% of the general population. With a country with a population of about 1.8 million, currently there are about 350,000 persons who are infected. And so this is a very major epidemic to kind of fight, and certainly one of the key impacts was a significant reduction in life expectancy of birth of about 10 years over a period of about a decade. Now, I have a little bit of water, if I may. Now, a key issue in terms of how this support was to be provided was really looking at issues of long-term sustainability, providing support that was aligned with the country's development plan, and also providing support which would have the prospects of being sustainable, since it was in line with the country's priorities. So one of the things that was done in terms of the partnership was to actually look at how it would be structured, such that over time, the country's own capacities and capabilities would be built. So the partnership model was one in which the partners would facilitate government-led initiatives and programs. One of the key things that was noted in terms of the national HIV/AIDS response and what was required was really quite a significant shortage of human resources. There were certainly financial gaps in terms of what was required in terms of the national response, as well as significant gaps in terms of infrastructure development requirements. But one of the key things that was felt to be necessary and that the partnership was trying to demonstrate was that private sector resources and approaches could be used to quickly leverage government's efforts, catalyze implementation, and provide strategic support. And so in that way, achieve greater coverage and impact, and enable innovation by using methods that would be used in the private sector as opposed to those in the public sector. This certainly, of course, was going to pose something of a problem and a challenge, especially in a setting where most of the initiatives and the strategies being driven by government. And I think early in the partnership caused some considerable challenges in terms of agreement on approaches, but I think eventually, after some initial challenges, it eventually developed into one in which you have a fairly good trust between the two partners in terms of how we proceed and move forward. Another unique aspect of this partnership was that while government was a partner, it was also one of the major recipients of the donor support, and its contribution was in kind in terms of policy and strategic guidance, as well as contributing human resources for program delivery. So, having painted the picture of Botswana's national HIV challenge and some of these impacts in terms of the development, what has been the impact in terms of how on Botswana's progress towards the Millennium Development Goals and the challenges that the country was facing. If one looks at the 2004 Millennium Development Goals report for Botswana, which was the first report that the country produced, this statement is made, which is, I think, quite telling, that HIV/AIDS is eroding the very viability of development strategies of the country, and that Botswana had hitherto pinned its hopes on for sustainable development, and that in just 2 decades has emerged as a phenomenal threat to everything that the country had achieved since independence and its prospects for realizing its future aspirations. And I've already mentioned some of the erosion of the health gains since the time of independence. Now, as has already been mentioned, whilst this partnership was focusing largely on HIV/AIDS, there's a very close linkage between several of the Millennium Development Goals. And in fact, HAP support, and lost my screen here, but that's okay. No, it's all right. Oh, there we are. HAP support, while focused on HIV/AIDS, certainly touched several other goals, and I think I won't mention their names, but just to illustrate some of the linkages between them. I think the most significant contribution, of course, is under Goal 6 in relation to HIV/AIDS treatment, and this I think is where the greatest contributions have been in terms of Botswana's development for the reasons that I've described earlier. But I think it's also interesting to note that since HIV/AIDS has so significantly affected young people, mainly in the population, with about 25% of the population who are economically active being HIV infected, this is also the area where most deaths were occurring. And so under Goal 1, certainly this kind of contribution that the program made, and I'll talk about its achievements in a moment, had a significant impact in terms of reducing poverty by maintaining people's productive capacities through the success of the national treatment program. And in the area of Goal 4, which is reducing child mortality, Botswana has achieved, with the support of partners such as HAP and other development partners in HIV/AIDS, one of the most successful prevention mother-to-child transmission programs, which has reduced the PMTCT transmission rate from between 20 to 40% when the program was initiated to less than 4% in the space of about a decade. And therefore, there have been very significant reductions in child mortality. But as I'll show you later, there are still some rather interesting challenges in the fact that despite this benefit, we haven't realized some of the reductions in infant mortality and under 5 mortality rate that one would have expected. The Prevention of Mother-to-Child Transmission program has also made an improvement, a contribution to improving maternal health, in the sense that not only have children benefited, but the PMTCT program also provided an opportunity later for extension of treatment to mothers of these children, first through the PMTCT program itself, and then later through expansion of Full Heart to cover women who are enrolling in the program. And therefore, this has been an important benefit in this area also. And under Goal 8, which is to develop a global partnership for development, I think Target 17, which deals with the pharmaceutical companies and their providing and improving access to essential drugs, has been another very important area in which Merck's contribution and the contribution of the partnership has provided access to treatment. Yeah. Okay, I seem to be learning how to handle the screen here. Now, one of the important things that I think, one of the examples of the successes that I'd like to talk about briefly is the National HIV/AIDS Treatment Program. As I mentioned, this was the first full-scale national treatment program that was established in sub-Saharan Africa. And I think what was novel about it was its boldness in terms of what was actually being attempted. When this program was started in the year 2000, rather in 2002, at least when it was being contemplated in the year 2000, there were significant doubts as to whether it would be feasible to launch a large-scale treatment program in a developing African setting, and whether it would even be operationally feasible or cost-effective in the long run, and whether it would even be sustainable. So with Merck's support and that of the Bill and Melinda Gates Foundation, a number of important processes went were gone into. First, the country had a very strong motive to be able to put in place such a program with 25% of its adult population HIV infected and such high rates of mortality as I've mentioned. And it was clear that if we didn't invest in this kind of program, then socio-economic development itself would be significantly affected, and probably the costs of not providing treatment would be greater in the long term than the cost of providing treatment. And what this graphic shows, which is a map of the country, it shows how, with HAP support, different clinics, about 35 infectious disease care clinics and satellite clinics, as well as providing infrastructure such as equipment in terms of testing, equipment in various level facilities, was actually distributed throughout the country, enabling the implementation of a truly national program. And of course, what is interesting about Botswana, even though the population is not very large at about 1.8 million, and is really based mainly along this eastern corridor, it therefore means you've got a fairly large country about the size of France, and therefore a very low population distribution. So providing services in this kind of environment can be a major challenge. But for the success of such a program, it was recognized that you then needed to do that, and this is why the density of facilities is much greater on the eastern corridor here, which is in line with the population density. And what I'm showing here is really what some of the program achievements have been. I think the first is that the country benefited by the establishment of a program of this nature, in the sense that its own citizens were able then to gain access to treatment. And when the program began in 2000, less than 5% of the population had access to treatment, and this was only really in the private sector. So with the decision to provide treatment in the public sector, with the support of Merck and the Bill and Melinda Gates Foundation through HAP, we've progressively been able to provide treatment now to about close to 150,000 people, and over 94% of those who need treatment are actually receiving it, as can be shown by the yellow line here, where this was the treatment gap at the beginning, and progressively as the program rolled out fairly rapidly, it now is moving along this line with really the majority of people needing it. So universal access has been reached certainly. But as I'll show in the next slide, one of the most important achievements is really the return on investment, in the sense that all the people who are on treatment now, the 150,000 plus who are on treatment, are people who without treatment would probably have died at this point in time. But what is also important, of course, is the fact that, as was mentioned earlier, it's only when you look at it in terms of the human perspective and not just the numbers. These are people who are now able to continue supporting their families and, of course, contributing to the country's economic growth. Another important lesson that was able to be learned was that despite the concerns about the poor adherence and whether in fact it would be feasible, Botswana's program has a fairly high level of treatment adherence at above 90%, and rivaling the kind of adherence levels that you would expect in a developed country setting. And perhaps the biggest contribution that the success of this treatment program made was that it was able to demonstrate that indeed such programs are feasible in developing country settings. And indeed, we believe that this is what has inspired the investment by many other organizations and also governments to support treatment programs in the developing world. And I think in this way, this is where some of the benefits of the more than 5 million people who now receive treatment in the developing world might have come from. So whilst this was an effort focused on a small country, in fact, I think the benefits have grown to many more people in other countries. What was novel and what was necessary was a very different approach in terms of how information and education is shared about the program, as is illustrated here, where the program was branded and it was called MASA, which in Setswana means a new dawn, and it was really giving a new opportunity to people and a new lease of life, which previously had not been possible. And I think it completely changed the face of the epidemic in the country, giving new hope, and I think has almost certainly made a very big contribution also to reducing the number of orphans in the country, and the prospects for continuing development, as you will see. One of the things that was necessary was to provide infrastructure and space for provision of the treatment program. And what you see here is what we call one of the infectious disease care clinics, which should be part of an existing facility, but which would provide space for ARV treatment, including pharmacy, lab, and other components. And this structure here is in a very remote part of the country in the northwest, which is in the desert near Namibia. And an important part of such programs is actually to reach all parts of the country to improve treatment access. And in terms of when you look at issues of return of investment, again, one of the arguments has been to try and put in place sustainable programs, which in the end would be a good and sound economic investment for the country. And to do that, we've also had to help generate data through modeling and other studies to assess what the impact of the treatment program has been. And as was mentioned on the slides that were just shown by Coca-Cola about the importance of partnerships, I think this is what partnership has been all about. The HAP, or that particular partnership, was critical for Botswana in that it came at a time when all other forms of development assistance targeting the health sector had effectively disappeared. But what it's done is it's attracted many other partners back to address such a huge problem for a country such as ours and in other parts of our subcontinent. But I think the important thing for the economists and for the Ministry of Finance and others was that it's been able to demonstrate with the right kind of research being done that it's actually saving lives, not only the lives of the 150,000 or so people on treatment who would otherwise have been leading much less productive lives, but we've done estimates to demonstrate that between 2002, when the program began, and 2007, about 53,000 lives were saved by the impact of this program. And if you're looking at in a setting where you're estimating that about 300,000 people are actually HIV infected in a population of 1.8 million, this is a very significant achievement in terms of its impact on the society and the prospects for development for that particular country. And I'll also touch briefly on some of the prevention programs. And as I mentioned, I think I've already given some of this data for the prevention of mother-to-child transmission program, which has really been exemplary in the rate at which it's been able to expand and the kind of coverage rates that have been reached. But I think the issue that I'd like to illustrate here is that when the program started in 1999 and was finally rolled out to the entire country in 2001, for a few years after that, we had fairly disappointing uptake rates where in 2003, the rates were still around 28% of people who were eligible, and by the end of 2003, only about 40% of women who were eligible for this program were actually taking up the service. And through that work that was done, we were not really working very much in PMTCT at the time, but we saw the opportunity to support the other partners, who are working with government, UNICEF, and the CDC, PEPFAR, and others, and then provided training for a new cadre in terms of lay counselors, a different way of providing access to HIV testing in terms of the provision of rapid test kits, and importantly, supporting an initiative that the country was putting forward at the time in terms of which we call routine HIV testing, but which in other settings is now called provider-initiated testing, where we were trying to address the issue of missed opportunities, where patients were coming to health facilities, not discussing the issue of HIV/AIDS. Health workers being diffident about discussing the issue of HIV/AIDS, and then both the treatment program and PMTCT and other services suffering. As a result of this effort, working in concert with some of these other partners, the rate of uptake increased significantly. And by the end of 2006, over 80% of eligible women were now enrolling, and currently over 90% take up this treatment. And it's been estimated that in this way, a significant number of lives have been saved, and in the time between around 2004 and 2007, the estimates was that about between 7,000 and 10,000 children's lives would have been saved. And I think what is interesting about the routine HIV testing initiative is that the country actually got a lot of criticism at the beginning for this. And as a partner working in the country, we felt it was important to support it in terms of advocacy for this important initiative. And now as we speak, I think in many country settings, provider-initiated testing is in fact a fairly routine way of providing access to HIV testing and counseling. And so that has also been an important contribution, starting in this fairly modest setting, but now being of global importance. Other areas of support in terms of prevention programs have been for the support for in-school youth HIV prevention programs, as well as the support for the development of a national plan for scaling up prevention. With a country where there had been quite important achievement in terms of the national treatment program, and the change in the face of the epidemic, for one where really there was a lot of pessimism, and it was clearly known that anybody who got infected would in a few years die, the advent of treatment then meant there was the risk that people may then have less emphasis on prevention programs. And one of the things that was recognized was that, again, of course, you can't treat your way out of epidemics of this nature. And there are concerns, of course, about the sustainability of the treatment program. But more importantly, I think the HIV rates that Botswana is currently facing are still extremely high, and therefore there was an important need, if the impact of HIV on development in the long term was to be changed, to really scale up the rate at which, the success and scale of prevention programs. So HAP worked with the National AIDS Coordinating Agency to develop a national plan for scaling up prevention and really moving discussions about greater investment in prevention from rhetoric to action. And this national prevention program actually galvanized many other partners to support the initiatives that were identified, and is now the basis on which most partners are investing on prevention programs in the country, and has also inspired increased investment not only by partners such as ourselves, but the government of Botswana also. And these are, I think, I wanted to talk a little about some of these prevention programs. I've already discussed the PMTCT program and some of that data, so I won't go over this again. But I think the areas that really illustrated the severity of Botswana's epidemic was through the annual HIV seroprevalence testing, which started around 1992, and has been an important way of tracking this epidemic. And HAP made a very significant contribution in terms of improving access to HIV counseling and testing. And what these figures represent is if you look at this age group for the 25 to 49, the kind of increase that you would see in prevalence for this age group of women between the period of 1992 to 2009. But what was also interesting is that by disaggregating the prevalence by age group, it's clear here that there has been a reduction also in terms of prevalence amongst the younger age groups, particularly the 15 to 19 and the 20 to 24. So from the many HIV prevention interventions, some of which I haven't been able to discuss this afternoon, it's clear that there is some positive impact in terms of prevention in the country, although it's a little bit unclear as to what is causing this kind of reduction if one looks at it objectively. But fairly significant reductions have been achieved, of about 40% reduction in the 15 to 19 age group, and this is going to be the subject of further research as we look forward to try and see what it is that might be responsible for this kind of change. Now, I spoke a little earlier about the challenge of sustainability of programs. And I think one of the biggest challenges is how you sustain HIV treatment programs of this nature. An important part of that sustainability really comes from the way in which the programs are designed. In HAB's case, we wanted to make sure that we were helping governments start programs which they would, in the long term, be able to try and sustain themselves if we provided the right kind of framework at the beginning. And so in all the programs that were being supported, while we provided quite significant human resources and finances, and were the largest contributor of HIV/AIDS support in the early 2000s, of course, PEPFAR is a much larger provider now. One of the key things is that that model has enabled government to actually continue with most of the program implementation themselves. Whenever we constructed any structure for the HIV/AIDS program, we would then hand this over to government, and government would then be responsible for its maintenance. Over the life of our support for the ARV treatment program, which supported over close to 300 human resource positions in different cadres. But the way in which this was done was a way in which a small number of experts whom the system might not have been able to attract were supported as HAB staff. But for the majority, these were people who were supported on the basis of government-style contracts with the aim that government would eventually take over this capacity to be able to sustain it in the long term. And, yeah, 2 seconds.
It's so important. I'm very sorry to interrupt, but perhaps in the interest of time,
okay.
I could ask you to move to some conclusions.
Yeah, to wrap up, and I'll certainly do that. So we've talked about the treatment program, but I think amongst the key challenges are issues to do with prevention and the kind of investment that's necessary and how these will be sustained. I think an important program and initiative that is presently being supported is the male support for safe male circumcision, and also addressing the vulnerability of young women, which is demonstrated by these statistics here, where their HIV prevalence is much, much higher than that of young men of the same age groups. And therefore, in our second phase going forward, we're designing a program that will be addressing the vulnerability of these young women, which will hopefully change their future for them and the kind of path that they will face in terms of the epidemic going forward. And of course, with people who are not ill and who need to be encouraged to take up this kind of program, generating the kind of information and data that demonstrates the impact of these programs is an important part of actually convincing decision makers to make the necessary kind of investments. And as I mentioned, I did mention the challenge of infant mortality rates, which again might demonstrate the problems with focus on a single program when other aspects of the health service might then get weak as a result of this kind of focus. And I think that largely concludes my presentation, and I'd like to thank you for your attention.